Okay, let's move on to the first session. The first session is International Telemedicine Activity 1. The chairpersons are in this session, Dr. Xiaohui Ho, Associate Professor of the Medicine at the University of Malaysia. And Mr. Tunggul Laksono, Indonesia telemedicine engineer from the Brawijaya University, Indonesia. Okay, each paper in this session is allotted 15 minutes, and the further 12 minutes, and the further 3 minutes is available for the discussion and the question. Did you do that?
Thank you for the kind introductions. Thank you again for the kind introductions. Good morning, everyone. My name is Xiaohui Ho. I'm from University of Malaya, Kuala Lumpur, Malaysia. Okay, together with me, co-chairing this session is someone that really needs no introductions, Mr. Tunggul Laksono from Brawijaya University of Indonesia. So we would like to, express a sincere thank you to Temdec for inviting us to this 17 ATS. Yep. I remember I was introduced to this group perhaps as early as 2009 or 2010. That was easily about 14 years ago by my mentor, the late Professor K.L. Goh. In fact, maybe some of you is not aware of this. Professor K.L. Goh passed away in June this year. So sadly, he's dearly missed by all of us in my university. Okay, yes, like what Professor Shimizu mentions, nothing is unchanged. In this world, everything has changed. So let's brainstorm together today how to make our group even better. So without further ado, let me kickstart our first symposium of today by introducing our first speaker. In fact, he is joining us online, Dr. Miguel Tanimoto. So he will speak to us about telemedicine activities in Mexico and Latin America. So let's invite Dr. Tanimoto.
Thank you very much, Professor Ho, for your kind introduction. And it is a great honor for me to participate in this important telemedicine symposium in Japan. I want to thank Professor Shuji Shimizu, Professor Tomohiko Moriyama, and Engineer Kuriko Kudo for their kind invitation to develop this topic. I will share my screen. Well, the title of my presentation is Telemedicine in Mexico and Latin America. I have no financial conflicts of interest to disclosure concerning the presentation. And this is my hospital, the National Institute of Medical Sciences and Nutrition, Salvador Subirán. We have 44 medical departments and divisions, 8 medical specialties, 16 subspecialty programs, 42 postgraduate fellowship programs, 13 medical schools, 10 for undergraduate courses, and we have 221 beds. This is the outpatient building in which we have more than 290,000 medical consultations every year, and this is the new hospital building under construction. As you mentioned, before the pandemic, no one imagined or considered telemedicine present. Some even consider it irrelevant and that it could never replace the traditional practice with physical contact with the patient. However, isolation due to the pandemic has led us to have an accelerated acceptance of telemedicine globally. In an ideal world, research is financially supported. However, since the beginning of this telemedicine project, six years before the SARS-CoV-2 pandemic, we have not always had financial support for teleconferences, live demonstrations, consultations, case discussions with movie clips or slides with high definition. But thanks to TEMDEC, we have had IT and financial support at important venues in Mexico. Also, thanks to the technological infrastructure of TEMDEC, here is the Kyushu Hospital and a big network of Japanese friends who are key opinion leaders in endoscopy. We started self-financing using a laptop and a commercial internet line with a reasonable and stable bandwidth that connected to the TEMDEC infrastructure through the video platform with high-definition webcam and a microphone donated by Professor Shimizu and TEMDEC with a mute button. They could see and hear us, and the laptop then projected the received images through the projector, and we listened to the conferences with some commercial speakers. With the breakneck speed that technology continues to advance, as with artificial intelligence, cloud, apps, and social networking, clinical case discussion, webinars, and teleconsultations, new horizons have opened for the telemedicine. Nowadays, with platforms as Zoom, 5G networks, and gadgets that are increasingly available in any computer store, it is possible to create and participate in international symposiums like the one we are at now can be held. In 2014, thanks to the support of TEMDEC, we carry out the first live demonstration to our knowledge between two hospitals in Japan, one in Kyoto and the other one in Osaka at the Mexican DDW in Cancun. These are some images of the 5 Japanese opinion leaders who participated in the discussion table at the giant screens that broadcast the live cases from Japanese hospitals with an auditorium full of Congress attendees. In 2018, also with the support of TEMDEC, we successfully carried out the first telemedicine workshop in Mexico within the Mexican Digestive Disease Week in Mérida. Again, in 2015, we carried out a live demonstration between hospitals in Japan and Korea with the Mexican Digestive Disease Week in Mazatlan. And 6 years ago, we began a series of teleconferences with key opinion leaders in endoscopy on the diagnosis and endoscopic treatment of early esophageal, stomach, and intestinal cancer. Throughout 2 years, between 2016 and 2018, there were 16 conferences of 1 hour each. These conferences were held with the sole purpose of being a non-profit educational resource for the training of the new generations of gastroenterology endoscopists in Latin America. And this is an image of Professor Toyonaga lecture, Professor Uedo lecture, Professor Yao lecture. And thanks to a generous donation from the Cisca Company of the United States, the first telepresence room was built in our institution. This is an image of this telepresence room. We have air conditioning and high-tech displays. This is the inaugural ceremony of the Telemedicine Center at our institution. And therefore, since 2018, teleconferences between Japan and Mexico were held in this telepresence room. Also, between 2014 and 2023, we had participated in 31 Latin American endoscopy teleconferences together with several Latin American countries. In order that the lectures from Latin America participate together with leading experts from Japan, we decided to make a moderator turn for the medical case discussion. The next Latin American endoscopy will be held on March 2024. In May 2023, we organized a webinar together with the Inter-American Society of Digestive Endoscopy with great success. And since, as you know, since 2018, numerous papers on computer-aided diagnosis with artificial intelligence have been presented at international venues around the world. Nowadays, our interests in my institution are on big data and artificial intelligence because they represent challenges and new projects for our institution. These are some images of my wonderful stay sponsored by JICA and the Kyushu University for Nikkei doctors from Latin America. Finally, we are planning several webinars together with TEMDEC, the Inter-American Society of Digestive Endoscopy, and the Mexican Association of Gastrointestinal Endoscopy, starting on 2024. These are nice pictures. This was the beginning in 2014, and from 2023, the present and the future of this project. Thank you very much for TEMDEC. Telemedicine between my institution and worldwide now are connected. Thank you very much for your kind attention.
Thank you, Tanimoto, for your kind sharings of the activity in Latin America. Now we open the floor for Q&A. Is there any questions from the floor? Yes, Dr. Moriyama.
Thank you, Miguel, for your kind presentation, good presentation. So I just wonder the role of telemedicine in future. Actually, you know that in the endoscopy field, the AI technology is dramatically installed, and also everybody already noticed its usefulness. So I just wonder, just that telemedicine, the role of telemedicine for endoscopists. So I just would like to know your opinion.
Oh, yes, of course. It is very important, the role of telemedicine, because nowadays artificial intelligence is just a calculation of probabilities. But telemedicine are more than that. We can have very good and hot discussions about clinical cases between clinicians, endoscopists, radiologists, and pathologists. And this can help very much to the learning curve of new generations of young endoscopists. I think that telemedicine is a very powerful tool, and I'm thankful to be part of it together with TEMDEC. So I think the role of telemedicine is vital nowadays.
Thank you so much.
Thank you.
Yeah, I think echoing that question, also I would like to perhaps also share my thoughts on this. I think telemedicine, as we run here in our working group, basically helps spread the knowledge of endoscopy faster than the conventional meeting. So it helps to standardize, the endoscopy skill worldwide, perhaps in a faster manner than the conventional way. Yeah, and we have a huge network here, so you can see that Latin America, Japan to the rest of the Asia, which still, depends a lot on this kind of education to enhance their skills in a faster manner. So, yeah. Is there any other questions from the floor? Yes, Professor Shimizu.
Hello, Dr. Tanimoto.
Professor Shimizu, nice to see you.
I just want to say hello and thank you for joining this symposium and for making a very nice presentation, reviewing all our activities so far, with a beautiful slide. Thank you very much, and hope to see you again soon. Thanks.
Thank you very much to you, Professor Shimizu. You're the founder and the pioneer of this big group now.
Thank you. Thank you, Professor Shimizu, for your questions. Is there any other questions? Okay. If not, we thank Dr. Tanimoto once again for excellent presentations. Now I pass the mic to my co-chair.
Okay, thank you. And now for the second presenter, it's Dr. Nao Fujimori, a gastroenterologist from the Kyushu University Hospital, and he will be speak about the recent advance in interventional AUS for pancreobiliary disease, sharing through the AUS Asia teleconference. For Dr. Nao, time is yours. Thank you.
Okay. Thank you, Chairman, for your kind introduction. My name is Nao Fujimori from Kyushu University Hospital. So I'm a gastroenterologist and especially in the pancreatic disease. So today's my topic is interventional US. And I have no COI. So this slide shows today's agenda. I'd like two topics of the first is the recent advances of interventional endoscopic ultrasonography. This means EUS in Japan. And the next topic is the EUS Asia teleconference to share the skills of intervention. So before starting my presentation, I again thank you for the Telemedicine and Professor Shimizu and Kudo and Muyama for inviting me. And the pancreatic endoscopy consists of two procedures. The one is a ERCP-related procedure. It's a transpapillary, duodenal papillary approach, and this is maybe pancreatic cancer. And the other approach is US-related procedure. This means pancreatic transgastric or transduodenal, the puncture, and the US-related procedures. So pancreatic endoscopy, then ERCP is the basic procedure for pancreatic disease, such as stone extraction, biliary or pancreatic stenting. But it's on the other hand, interventional US, including US-guided tissue acquisition, USTA. This is a similar words of USFNA, fine needle aspiration, and US-guided transluminal drainage, USTD, and US-guided biliary drainage, USBD. These techniques is recently dramatically developed in our field. So we can use various devices for USTA or US-guided transluminal drainage. We mainly use echo endoscope and many kind of needle from the 90 gauge to 25 gauge needle. So I would like to show some schema or video of this our technique. This means USFNA concept of USTA. And you can see the pancreatic tumor in the pancreatic body. This is pancreatic cancer. And firstly, we inserted the echo endoscope. And the transgastric wall, we puncture the tumor and get histological samples to make a diagnosis. These are basic procedures of USFNA, USTA. This is actual videos when performing the USTA. You can see the hypoechoic tumor in pancreatic body or pancreatic tail, and the puncture using the FN needle. And in the tumor, we move to the flow and back and forth as a needle, and using some technique and to get histological samples to make a diagnosis. And USFNA is used not only diagnosis, but also the treatment for for example, the peripancreatic fluid collection, PFC. And previous reports, many reports, revealed that US-guided transluminal drainage, USTD, revealed high technical success and the clinical success, more than 90%. So I'd like to next talk to the USTD for the PFC, pancreatic fluid collection. This patient has a surgery 5 weeks ago, and he has abdominal pain, and PFC is rapidly increasing in size. So we we decided to perform USTD with LAMS. The LAMS is like a unique shape, the new devices using VSFNA USTD. This is the video of the USTD using the LAMS. So it's a endoscope the ultrasonographic view. And first we inserted the LAMS under EUS guidance. And in the POPF, we put back the LAMS to adhere the gastric wall. And the next, finally, this is the endoscopic view. We inserted the LAMS. And after the insertion of the LAMS, you can see the much amount of the fluid backflow to the stomach. And this patient is dramatically improved. And the final topics of our field is US-guided biliary drainage. So maybe the pancreatic cancer obstructs the bile duct, obstructs jaundice. So we perform the first step is the biliary drainage using ERCP. But some case, for example, the duodenal obstruction due to the pancreatic cancer, we could not insert the duodenal scope to the papilla. So in these cases, we consider to perform ES-guided biliary drainage, USPD. ESPD is a puncture from the stomach to the left intrahepatic bile duct, or from the duodenum to the CBD. And I again share out the video, video of the ESPD. The first step is similar with ESTA, insert the echo endoscope, and from the stomach to puncture the left intrahepatic bile duct, and the insertions of the guide wire. You can see the stenosis due to pancreatic cancer. And finally, next step, after tract dilation, we inserted the metallic stent to the stomach and the liver. And we completed biliary drainage using these techniques. The bile juice go back to the stomach. I will introduce only one case, pancreatic cancer with duodenal obstruction. This patient has severe acute cholangitis and very old patients, and it's not candidate for the surgery and poor performance status. So PTGBD, percutaneous drainage, was firstly performed. And the next session, we plan to the endoscopic intervention. So firstly, we confirm the duodenal stenosis and inserted the duodenal stent using the endoscopy. And after the insertion of the duodenal stent, we perform the move to the USPD. And this is the liver and the puncture using the FNA needle to the intrahepatic, left intrahepatic bile duct, and the contrast injection. You can see the bile duct from the stomach approach. I think this is very useful and amazing procedure. And insertion the guide wire, and the insertions are metallic stents to the from the stomach to the bile duct. This is endoscopic view with PD. So I'd like to summarize shortly. So interventional US, as I mentioned, is very useful for the management of our disease. But however, this advanced procedure requires sophisticated skill and are not yet widespread especially in Southeast Asian countries other than Japan. So therefore, we started a teleconference regarding interventional US to share skills and knowledge of this technique since 2019, just before COVID-19 pandemic. So before COVID-19, we frequently go abroad and made an international exchange, such as this is Indonesia, Vietnam, Philippines, and China. And we made a live demonstration using endoscopy. But it's, as you know, after COVID-19, sometimes difficult situation. But it's in this condition, telemedicine or USA teleconference is very important, I think. So we conducted this conference to, in this conference, exchange information and remote learning, such as ES screening, standard technique of intervention US. This main concept is to share the US skill And the participating institution are our Kyushu University and the other Asian countries, such as including Indonesia, Thailand, Malaysia, China, Vietnam. And the aim of the main of this conference to share and standardize procedure of intervention in US and to improve, finally, to improve prognosis of pancreatic disease, especially with the pancreatic cancer. It's a very fatal disease. This is a schema of the picture of the conference. From Japan, our Kyushu University, and from Vietnam, Chore Hospital and University Malaya, and Fudan from the China, or UI, Indonesia, and Chulalongkorn Hospital from the Thailand and Taiwan University. So we conducted this conference every 4 months since 2019. And last October, we held the 15th US Asia teleconference. It's now ongoing. And in every conference, and some institutions present, so two or three or four institutions present regarding US guided procedure or US FNA or US screening. And the mean number of participating institutions or countries from the 6 to 8. So many countries or many doctors participate in this conference since 2019. And every conference, we make a questionnaire survey to improve our quality of teleconference. And now it's supported by the Telemedicine. Our conference video is posted on Telemedicine by YouTube channel. So everyone and every time you can, I myself check our presentation or the other countries' presentation. And I would like to show shortly the results of the questionnaire. The first question is, how was your satisfaction with the discussion? And from the first and the 10th teleconference, the proportion of the satisfied or the relatively satisfied, the satisfaction proportion is 86%. And then now it's from until the 50th teleconference, the proportion of the satisfaction is improved to 96%. So that means that most doctors or engineers have the satisfaction of our conference. And the other topic is how was your satisfaction with the discussion? Also, sorry. And the next topic is how this conference helped your institution to improve your skill. And definitely yes was 60%, and just 40% is yes. So more than 95% of doctors or engineers feels that this conference is useful for sharing our intervention skill. So it's in this July, we held the annual meeting of the Japanese Pancreas Society. And in this conference, we made an Asian symposium, namely intervention with pancreatic diseases. I have a chance to chair this conference with Professor Takao Itoi. And in this meeting, I invited 4 doctors, 4 overseas doctors from this US Asia conference from Taiwan, Madam Chai from Thai, and June from the Vietnam, and Dr. Ku from the Malaysia. And this is not web conference and the face-to-face conference. I think it's, of course, the teleconference is very important, but more important. So face-to-face communication, in-person communication is important, I think. So I again thank you to the support by the Telemedicine and giving me the big chance. Okay, I summarize my presentation. Interventional US plays a significant role for the management of the patients with pancreatic disease. And our ESG conference, now ongoing conference, international web conference is useful for sharing cutting-edge endoscopic treatment. Thank you again for your kind attention.
Thank you for Dr. Fujimori for the nice presentation. Okay, now I ask if there are any question from the floor. Is there anyone? Okay, Professor. Dr. Ho.
Sorry. Okay, Dr. Fujimori, I would like to find out from you, this is perhaps slightly technical, because the EUS that we endoscopists use, the monitor is a different types of monitor. It's a monitor that can display 100 shades of gray, so that you can see the black-white differentiation very clearly. But during teleconference, it is just a normal monitor. And furthermore, the surroundings are white color, very colorful. So it is very distracting. Is that a way to overcome this? I'm not sure.
Oh, I'm not sure the technical aspects is very difficult to answer.
Yeah, maybe these engineers, perhaps
Yes.
you can think about it in future. I don't know how to overcome that, how to improve the grade differentiation, the shades of gray. This is very important in US, especially in US, because they are looking at black and white, not the colorful images.
To deliver gray image to the telemedicine in the area.
Yes, but of course it is down to hardware, I suppose, in the end.
Is there such a difference in quality, image quality in US? Still big difference in quality
Maybe
between
expert document.
in on-site and the
I think not so different. So image quality is just same. It depends on the echo itself.
Oh.
Okay.
Okay.
Yes.
Okay. Dr. Tomato.
Yes, thank you very much. As in US, you have hundreds of shades of gray. Also, artificial intelligence use these shades of gray and to sectorize and to identify in between hundreds or sometimes thousands of images to have a probabilistic calculation of identification of the lesions. What is the role of artificial intelligence nowadays in Japan, in US?
Oh, thank you for a good question. So as you mentioned in the last presentation, US AI is one of the most important field. And now ongoing, US picture is make a diagnosis near similar with endoscopy viewing. So now it's just same as colonoscopy AI. US AI is now developing to make the pancreas cyst or to make to confirm the pancreatic cancer and the differentiation. In the near future, it's maybe 2 or 3 years, maybe. I think it's USAI is clinically usable in our field. It's my opinion and my hope.
Okay, thank you. Thank you. Is there any, Professor Mitsu? Oh, Dr. Arya. Oh, Dr. Arya first.
Good morning, Prof. I'm not a surgeon, I'm a medical doctor, but I'm interested in the way you do the medical education here to train the skill. So how you make sure or how you certify that the people that you train is skillful to practice in the telemedicine approach?
Yes, but very important and very difficult question. So it's just same as the surgery, I think, the endoscopy training. The first we see the doctor, and the next step is to perform together, and after that is teach, and our advisor, our senior endoscopist to see the performance of the young doctors. It's a 3 steps. It's the same, but it's no way to the no way to the answer. But it's very important our goal. Okay.
Okay, thank you. Because of limited time, has already done. Thank you so much, Dr. Fujimori, for your nice presentation.
Thank you.
Big applause for Dr. Fujimori. And now we are next to the next presenter. Okay, Dr. Ho.
Okay, our next speaker is joining us online. She is Dr. Bobata Gatunya from the Mongolian National University of Medical Sciences, Department of Gastroenterology and Hepatology. So she will speak to us on human resource development for GI diseases in Mongolia. So Dr. Gantuya, the floor is yours. Dr. Gantuya, you can start.
Hello? Oh,
Yes, we can hear you.
thank you very much for your kind introduction. First, good morning, everyone. First of all, I would like to express my appreciation to TEMDEC team to invite me in such honored meeting. So in Mongolia, there's five leading disease. Is the first is respiratory system disease, and second one is the digestive disease system.
Bantuya, sorry to interrupt. Your slide is not it's centered. It's cut off.
Mhm.
Okay.
Now, can you see my
Still
slide?
cut off on the left side. Okay, thank you very much.
Now it's okay?
Okay.
Okay, okay. Okay. So Mongolia is the first leading countries for liver cancer, and for stomach cancer is first leading country, and also esophageal cancer is second highest country in the world. That's why we started gastrointestinal disease is the highest disease in Mongolia. So therefore, the TEMDEC activity is focused on the gastrointestinal disease among Mongolian people. So this is our hospital. Our hospital is the Mongolia-Japan Hospital. Is the very biggest university in Mongolia. So first time, TEMDEC team, our colleague, Dr. Eva introduced TEMDEC in our country first time. And in 2019, Dr. Shimizu and Dr. Tomohiko Moriyama and Ms. Kurita came to Mongolia first time. Since then, TEMDEC activities started in Mongolia. And 2020, I visited TEMDEC first time. That time I learned lots of endoscopic diagnosis and interventional endoscopy. And then I also appealing our colleague and TEMDEC activity second time visiting to Mongolia in 2020. The very big team came to Mongolia, and Dr. Tomohiko Moriyama and his colleagues came to Mongolia and introduced our Mongolia-Japan Hospital and also Mongolian National University of Medical Sciences. After that, the very big project started. Since then, several times, TEMDEC team, endoscopic team, and surgeon team, IT engineers, and pathologists, radiologists, and oncologists came to Mongolia to teach us the hands-on training and also give the wonderful lectures to educate our Mongolian doctors. Due to the TEMDEC activities, our knowledge is improved by the esteemed professors' lectures. And during the COVID-19, we also conducted several telemedicine activities. We organized several webinars. And TEMDEC team visiting our countries and also organizing the live demonstration and bedside training. Here's our endoscopy department, and Dr. Moriyama teach us how to do diagnostic endoscopy using NBI and Zoom endoscopy, and also he showed us the live demonstration to do ESD or EMR. And we also collaborating with our surgeons. And from the TEMDEC team, Kyushu Medical University Hospital, several surgeon doctors came to our hospital also, and we did several laparoscopic surgery and legs procedures. During the visiting, also IT engineers team came to Mongolia, and that time our engineers also trained how to conduct telemedicine activity. And last year, seven doctors came to Japan to study 1 month observational study. It was very fruitful. And this time also 7 doctors visited to the Kyushu University Hospital. And last time, again, 7 doctors visited, come to the Kyushu Medical Hospital. Totally 8 endoscopic doctors and 5 surgeon doctors and 3 IT engineers and 1 pathologist, 1 radiologist, 1 oncologist doctors already trained in Kyushu Medical University Hospital. During the study, we learned about diagnostic endoscopy for early GI cancer, and we also observed very rare cases and ERCP, US, ESD, and many other interventional endoscopic procedures during our visiting. We also learned how to perform ESD and how to perform ERCP, and there's several hands-on equipments supporting our training. During our training in Kyushu University Hospital, we also visited Chikushu Hospital to meet Dr. Yao, and we also learned many important things in Chikushu Hospital. By the TEMDEC activity, our endoscopic team developed after TEMDEC training, several TEMDEC training. We performed ESD and EMR procedures, collaborating with TEMDEC doctors. And our surgeon team also developed by their skills. Laparoscopic surgeon skills also improved. Also, we first time introduced our hospital legs procedures. First time we did together with TEMDEC team. And also our IT engineers receive many devices from the TEMDEC team. Also, we organized, still we are organizing very good teleconference activities. We also not only training activities, we also very much enjoyed Japanese wonderful culture and wonderful friendship with TEMDEC teams. Nowadays, we did several ESD and legs procedures ourselves after TEMDEC activities. I would like to express my special thanks for TEMDEC team, Kyushu University Hospital. Thank you very much for your kind attention.
Thank you, Dr. Gantuya, for your very interesting presentations. Now we open the floor for question and answer. So has anyone any questions for Dr. Gantuya? Dr. Moriyama.
Okay, thank you, Ghana, for your nice presentation. Actually, you joined not only the webinar for Mongolia, but in our telemedicine, like in a Russian teleconference or other Asian teleconference or something like that. So, but this program for Mongolia is a kind of a special, because we can combine the on-site training, invitation program, and telemedicine. So I suppose that you understand the difference between the teleconference alone and this kind of combination education. So I just would like to know the difference between these 2 kind of activities.
Excuse me.
Do you think that this kind of telemedicine alone is not is insufficient for education, or it's okay to share the knowledge and the experience among doctors or something?
Yeah, this combination is very suitable. Not only hands-on training, but also TEMDEC activity is showing. Sometimes we would like to discuss on patient in absence of the TEMDEC team. We would like to discuss about the disease diagnosis and treatment strategy. So in that purpose, the combination is very essential for developing the human resource in the future.
Okay, thank you.
I think I have the same questions and thought flow as Dr. Moriyama, because I think every needs of every center is different. Maybe for the center that newly develops a skill, they will need more than just telemedicine discussions. They will need a hands-on coaching. So a visit from TEMDEC's team, expert visit to the hospital and coach them will be very much helpful than just telemedicine activity alone. But of course, once the skill develop, then a telemedicine discussion perhaps will be enough, I think, my opinion. Any other questions from the floor? It is certainly very great to see how Mongolia develops so many skills in just a short period of time. And that is also a thing called the ESD virtual coaching. I think it was done in Latin America before, whereby they perform ESD, and then the video was recorded and sent to an expert for opinion. But of course, it doesn't have to be same time. The expert can comment at their leisure times, and then they provide valuable tips and tricks. I'm not sure whether this is from Latin America, but Professor Tanimoto, am I correct, or some other country?
No, you are absolutely right. I'm very happy to hear about the wonderful experience between Mongolia and Japan. And of course, I'm completely agree with you about the combination of hands-on and telemedicine. And I'm completely agree that once you dominate the ESD technique, maybe teleconference are enough. Yes.
Thank you. Yep.
Okay, is there any other question from the floor? Okay, if not, we say thanks to all the presenter for this session, and thank you so much. And we have a nice meeting for the day. I hope that we will have something can we get from this meeting that we can take the about the gastroendoscopic lessons that we have learned for today. And now we have moved to the next session. Please, Mr. Yumimori, you can continue the meeting. Thank you so much, Pri and Professor Ho, for chair for this session. Thank you.